So, kia ora te whānau, ko Edward Gane, tōku ingoa. I'm a hepatitis doctor. I help write the National Hepatitis C Action Plan. So I'm here, as we've heard from Mark and the previous speaker, there are a lot of similarities in our plans. We launched our plan World Hepatitis Day in 2021. Aisha Verrill launched that with us. And we've been active now for 3 years. And I think in terms of lessons learned, I think we've learned good lessons and bad lessons from what we've done to date. We've learned a lot from your work and your success. And if we look at really how phenomenally successful you've been in terms of reducing mortality from HIV in this country, and I really applaud the work which has gone into advocacy, awareness, testing and treatment. If you compare that to what's happened with hepatitis C, we have around, we think, 25,000 people still living with Hep C in this country. And although the mortality has plateaued, we've got a long way to go. And I think that reflects issues we've had with awareness, testing and treatment, and stigma. Stigma for hepatitis C, of course, surrounds the association with injecting drug use, which is still an illegal activity in this country. We were going really well when, we unlike HIV, we have a finite cure now. 8 weeks will cure almost everyone, well over 99%. So there's a real incentive to get out and find people. And when our treatment was initially funded in February 2019, we were treating about 600 people a month. And you can see how a lot of people who are diagnosed were rapidly treated and cured. We've failed to continue high rates of treatment because of lack of diagnosis. And lack of diagnosis reflects lack of testing, of course. We need to be treating and curing well over 2,500 people to meet the World Health Organization elimination goals. We're currently curing around 400 a year. So we've got a long way to go. And this was the impetus, of course, for the national plan, as I said, which we mentioned. And with the plan, we had an implementation plan. Very much the focus areas, as you've heard in the previous talk. And to get back on track, we need to find, for us, our biggest challenge is finding the undiagnosed. We think around 20,000 New Zealanders, and that's based on the numbers of liver cancer we see every year, which hasn't gone down. And liver cancer is a terrible endpoint because it's almost always associated with a very short survival. And that number is still around 80 to 100 a year, Kiwis dying from that. So we have two phases, two 5-year phases. And the first phase is raising awareness, and you've heard about the Stick It to Hep C campaign. This is a really attention-grabbing campaign, and it did work. It worked when we first launched it. There are a few grumpy people who complained, but we managed to overcome that, and it's been relaunched in July of this year. And we are seeing subsequently an increase in testing and diagnosis. So it does work. And we need to make testing more available in the community at our high priority settings, in particular for Māori and particularly for people who are currently injecting drugs, by taking the testing to our needle exchanges, to our pharmacies. And the one success we've had is point of care testing, like the RAT test, but on blood. And this is, we use the SD byline test. Very simple. We've trained the Kāwhena and the peer workers to do this in our needle exchanges, and they do a great job. And we're now, several of the regions, 3 of the 4 regions now have mobile vans which go out and test people in remote areas as well. And numbers have gone up and up and up. Last year, around 11,000 people had a hepatitis C antibody test, and the positive rate was 5%. They don't all have active infection, many have had previous infection, but that's about 10 times, we think, the background rate we would have expected. So we are targeting the priority populations. That's only antibody. You need to confirm infection with an RNA, the virus genome. And for that, we're moving towards dry blood spot. We did try with the Cepheid RNA machines, but we have not pursued those because of cost. We're now, and I'd like to thank the next speaker, I think, and this is really due to the work by Gary, and I know that Gary and Peter Saxton worked on developing dry blood spot testing here. You're well aware of how it's done. It's a finger prick onto particular blotting paper, fill in the spots, and then sending the spots to a lab. You can mail them, you can courier them, and they remain usable at ambient temperature for some days. The issue with this is poor, it's not that great for antibody. So we still need those SD-bar line rat tests for antibody testing, but for RNA, it's superb. Now, I've put sensitivity for the antibody. That varies. With the work which Peter and Gary did, it was really high, 84%. But for the work we did, and we did a large seroprevalence study at the needle exchanges in K Road and Welsford and Manukau 18 months ago of Jeff Noller. The DBS was done then at St Vincent's, and we had a sensitivity for antibody for only 36%. So it's nowhere near as good as RNA, where it's very, very good. And I'll thank Gary again. There is no approved method for using dry blood spot for HCV RNA. So Gary validated it locally and improved it. And so with the samples he used, spike samples plus non-negative samples, sensitivity of almost 98% overall. But, you know, if you have an RNA for Hep C of less than 150, almost certainly you have cleared the infection or you're clearing the infection. So if you look at what marks a significant viremia, the dry blood spot was fabulous. And we're now, are now providing this both here at Lab Plus, but also Tim, I'm not sure if Tim Blackmore's here, Tim's also providing this in the Wellington region as well. And people can mail these from around the Motu. So we have a very simple algorithm now for our pharmacies and our needle exchanges. It's all point of care finger prick or finger prick DBS to the lab, bring the patient back, the client back, and treat them. One thing which I would like to mention, it's not particularly about testing, but it's hugely important in terms of delivering treatment, is thanks to the work of Natalie Gould, we have managed to get Mavorite, which is a single cure for hepatitis C, reclassified. It took about 3 years. Pharmac has reclassified Mavorite, so now you don't have to be a doctor to treat. So all our nurses and all our pharmacists can do a simple online course, and they can treat without the need for a doctor's prescription. And I think that's hugely important in improving access to treatment. We're the first country in the world to actually allow that. Yeah. Now, the people who did all the hard work aren't here, unfortunately. But you know, that's hugely important because that will support our initiatives to increase testing and diagnosis. Now, the next 5 years is what we talked about briefly in the last talk, is we're really good at targeting the priority populations. People who are currently injecting drugs, people in prison who have a very high rate. We're very good, but it's a general population, people who last injected 20 years, 30 years ago, who don't identify or don't get tested. We need to have a wider general population testing program, very much like I'm sure you'll want to talk about. And we've looked at non-targeted testing programs. There's a very good program in the Awanui Labs, which has just finished, where they tested 3,000 people who walked through the door. We're also very interested in emergency departments, and again, I'll thank Gary for all the work he's done here. We're still not doing general population, general universal ED testing, but I think we should, and I'll show you why. But we do have a pelvic inflammatory disease pathway where a woman will have all STI and BBVI testing done, and we've picked up over 50 unknown cases of Hep C through this pathway over the last couple of years. Gary has a great idea for reflex testing for anyone with abnormal LFTs, because that will be a very enriched sample of people with Hep C. And I'll come to universal testing. Universal testing, I think it's great, but there are huge barriers, ethical barriers we need to overcome. But I'm sure many of you are aware of what's going on around the world. This is really standard practice in many places in the US, in Europe, in Sydney now. Most of the hospitals in South and Central Sydney are now doing universal testing, but the biggest success has been England. Why should we do it? The ED population is enriched with people living with hepatitis C. It's very cost effective. There have been about 5 or 6 very good cost effectiveness analyses done, which shown it's highly cost effective and much more cost effective than other screening programs. This, I think, is the reason why we should be doing it. You're aware that in England, initially 5 EDs in Brighton, London and Manchester set up universal HIV testing for everyone who is having blood work done. This is great, and then the Hepatitis C group, run by a colleague, a good friend of mine, added on, said that the England Elimination strategy would like to fund Hep C testing, and that's expanded actually to Hep B as well. This is a younger population, and it's been really successful. I get the quarterly numbers. So this is up until the beginning of the year. In the first 8 months, they had tested just under 3 million ED attendees. These are people who have blood work. It's prioritised. If there's enough leftover blood, they have an HIV test, and then Hep C and Hep B. If you just look purely in terms of numbers of new people detected, they've detected almost 1,800 people with hepatitis C, none of whom were linked to care, and almost 90% who had never had a test. And the majority have already been linked with care, and they have peer workers from the Hepatitis C Trust going and finding and talking to the others. It's also been incredibly successful for HIV. You may be aware of this data, that they've found over 1,000 people with HIV who are not linked to care, and they've managed to link them with care. And hepatitis B, let me not forget hepatitis B. So I think this has merit, but there are huge ethical barriers we need to overcome in this country to be able to progress this. I know that the STVBI is very supportive. General population testing, many countries of the world use it. As part of our plan, we were going to investigate general population testing in primary care, with everyone being tested for hepatitis C and also hepatitis B. If you're going to do hepatitis C, you should do hepatitis B. And of course, your question is, should we do HIV as well? So I'll finish there just by saying, I think we're really trying to test innovative practices. I think we've been really successful with our point of care testing. And I do think the reclassification of treatment has been hugely successful and will continue to be so. Thanks.